So here's our AP knee. We see the femur, the tibia, the fibula on the lateral side, and the patella is going to be this little circle thing superimposed over the distal femur. We know it's a good image because you have this open joint space, and to get that open joint space, you want to put a varying tube angle depending on your patient size. So if your patient's distance from their ASIS to tabletop is less than 18 centimeters, you're going to put a tube angle of 3 to 5 degrees caudad toward their feet. If their distance from their ASIS to tabletop is between 19 and 24 centimeters, so like a mid-sized person, then you do perpendicular. And if they have a rather large pelvis, so from the distance from their ASIS to tabletop is greater than 24 or greater than 25 centimeters, then you're going to want to do a 3 to 5 degree cephalic angle. And that's going to open up this joint space here so that you can see this intercondylar eminence. So we have the tibiocondyles, we have the lateral and medial femoral condyles, and then the epicondyles above them. We know this is a right knee because the way that it's hung, if it's anatomically correct, the fibula is going to be on the lateral side, so we know it's a right. Okay, so moving on, we've got AP oblique with medial rotation. You know it's medial because when you move the leg of the patient, their patella is going to move towards the medial side, which will be above the tibia. If it was laterally rotated, you would see the patella over on the fibular side. So that's how we know that it's medial, and that's gonna free the fibular head from any superimposition. So we see this little line in between, and that's what you want to see there. For the lateral knee, you want to have the patient bend their knee 20 to 30 degrees. You see the patella in profile here, and for the tube angle, you always, doesn't matter who your patient is, you always put a 5 to 7 degree cephalic angle, because the medial condyle of the femur is always going to be lower than the lateral. So here it's good. It's a good angle because you don't see any it's very well superimposed. So if it wasn't properly angled or properly positioned, you would notice the rotation right in this general area. So this looks good. Okay. This is slang term is tunnel view, but it's the intercondylar fossa. So here, you don't see this on the AP. So this is the really big area for the intercondylar fossa. It's called a fossa because it's a big indent, I guess, or a depression. And that's where this intercondylar eminence, sits, and it gives it some room. So we want to keep this joint space open too, so that's why the angles are so important. For this view, this is actually a really good picture. It's sometimes hard to get the intercondylar fossa because when you bend the knee and you're angling, it whites out a lot at the thigh, over by the femur. So this is a great photo. Okay, and then this is the sunset view, but it's really called a tangential patella. That's when we did the Settegast method. So, you bend your knee, and you're trying to isolate the patella to see if there's any, potential fracture problem between the patella and the femur. So we just want to have a nice open joint space. You want to have your patella perpendicular to the IR, and then your central ray perpendicular to the IR, and you want to shoot it right through this space to get it nice and open. And that's to check for the patella by itself. So that is our knee exam and all of our images.